Hey, it's me, Jen again, and today we're learning more about laser ablation for thyroid nodules. We'll be joined by interventional endocrinologist Dr. Alex Manzano coming up. Dr. Manzano, based in Miami, Florida, learned about interventional thyroid procedures during his fellowship training. Today, he shares with us his experience helping patients avoid unnecessary surgeries and how insurance coverage is now available for laser ablation procedures. I'm just so excited to meet you and talk with you because I've not had as much opportunity to speak with laser providers, and I've not yet met any patients who've had laser. So I'm really excited to learn more about it and hear what your experience has been. Please give me a little bit of a background story on you and how you got into medicine and how you got into this field of endocrinology.
So I'm originally from Ecuador, a small town in the coast called Guayaquil. So I went to medical school there, came to the US to do what is called medicine residency in internal medicine.
Mhm.
And I was accepted in one of the Yale New Haven hospitals. It's called the St. Raphael campus in New Haven. So I spent there 3 years. After that, I served as a chief resident for the internal medicine program at the University of Miami. And then during that time, I already got the feeling for endocrinology and hormones. And later, I got accepted into fellowship at the University of Miami as well, where I did 2 years of training. That was 2012 to 14. After that, I joined a private practice and been working doing, we could say 50% of the time thyroid focus only, 50% of the time endocrinology. And in the last year and a half, I decided with my two other associates to create our own practice. So I've been doing my own private practice in the last year and a half.
And are you enjoying that? Is that a bit different for being in a hospital system?
It is. It has its challenges. Just you're in charge. You make decisions. It's good. Also, you can lean more towards doing things that you like. Like for example, thyroid laser ablation. We have doctors that would like to do other things in the same field, right? Of endocrinology. So you have more opportunities.
That's exciting. Yeah, innovation seems to be happening in private practices than it can actually happen in these bigger hospital systems because there is red tape and there is a lot that you have to deal with when you're trying to implement these new strategies to help patients. So it's really exciting to see what this is doing for medicine. So tell me a bit about why you decided to adopt laser ablation.
So laser ablation, I've been following it during fellowship training, at least 2012, reading all the papers from Italy mainly, some of the South Korean reports as well. As time moved forward, getting exposed a lot to thyroid nodular disease. All these questions comes to your head, like what if we could have this technology here in the US to help our patients and avoid unnecessary surgeries, of course. Somewhere around 2019, when this idea came to really push or get trained or find ways to get involved. So laser ablation, we thought it was going to be something more feasible to implement right away. And laser, we thought it was going to be also more practical for benefit of our patients, less complications. So we analyzed all those three variables and we decided to start first. We don't know what the future will bring, but from right now, that was the decision to start laser ablation for thyroid nodules.
You mentioned earlier your training experience was in Italy. Can you tell us a little bit about that?
I was able to get in contact with, I guess, a company who produces or brought the technology to the US, Laser, and they were able to fit me in one of their trainings in Italy. So I had the pleasure and honor, I should say, to meet Professor, excuse me, Gianpaolo Papi in the city of Carpi in Italy, small town, Emilia Reggiana location in the center of Italy, where we had two sessions, 2 days. One was more clinical, going over the procedure in terminology and how exactly the laser will work. And the second was hands-on training session, 4 or 5 patients, if I'm not wrong. So that's interesting to see how many cases can you do in one half morning. Dr. Papi has tremendous experience. I had the opportunity to see some of his follow-ups as well. And these were 6 and 12 months follow-up, and it was nice to see all the transition of images.
I recently was on travel and got to meet several RFA patients and see their follow-ups. And you're right, it's exciting to see the changes that have happened over time as their nodule has shrunk. That was probably encouraging to you as you were pursuing offering this in your own practice.
Yes, that's right. Of course, we try to, as you clearly said on all your communication platforms, saving the thyroid is key at this time. We have the means, we have the tools. This is open to everybody. It's not for specific hospitals or clinics. This should be something that eventually, with your help in a way, and promoting data as we have it already on the big journals in thyroid and other journals in endocrinology, this is something that we could at the end of the day help patients and avoid unnecessary surgeries.
Absolutely. That's the goal. We want patients to maintain their thyroid health and their quality of life. So how is it going in your practice now? How many procedures have you been able to do so far?
So yeah, so far since we started, we have a total of 4 cases. We had 1 follow-up already that is showing improvement of some limitations with this patient in particular. He comes from abroad. We are actually having today in the afternoon 2 other discussions. We normally do a session to explain patients how's the procedure, cost, and what to expect, possible complications, etc., on a particular session. So I have 2 patients today for that. So far, the results are going good. We haven't had any complications. It's something that slowly will grow more. It's great to be offering laser ablation to patients with medium or large thyroid nodules, because insurances are starting to offer coverage for the procedure. So we have seen it in 2 of our cases already. And that's huge. It's humongous compared to 2 years ago, when some of these procedures were limited due to high cost and expenses out of pocket in some cases.
Can you tell me a little bit more about the insurance coverage? What was the patient's out-of-pocket expenses?
So in details, these 2 patients had a very low copay, and reimbursement came as it was told to our office. So the out-of-pocket deductible wasn't that high. From what I've heard talking to other doctors in the same field of thyroid ablation procedures in other states, they're already getting reimbursement even from Medicare, from one doctor told me. So I think it is already happening, and that will open more doors for patients to have this accessible.
It's very much a barrier for patients having the financial burden. And so many of them will even say, well, I'll just have surgery because at least that's covered by insurance. And I really just, that saddens me to hear patients say that, because they're thinking more about their cost than they are about their health. However, it is a very real factor that has to be considered when making these kinds of choices. So it's wonderful that now we're starting to see insurance coverage and that patients can actually take advantage of these procedures and use their insurance together. Let's talk a little bit about your collaborating with other physicians who offer this. Are you doing any kind of physician training or offering the opportunity for physicians to observe your cases?
Right. At the present time, we haven't started that process yet. I think it was a conversation that we had with the Italian doctors during training. As we were going, in my case, it was just me alone to Italy to get trained. In the future, they were saying, you should start the same. And I think it's something that we have looked into. We're trying to build more cases to have more, not necessarily hands-on, but more volume of cases on 1 or 2 sessions, so possible trainees can get the full experience. It's something that it's doable. I'm sure that eventually you won't have to travel outside of the US to get this training, since there's already some other centers in the US using laser ablation techniques.
Yeah, given that you are one of the first, I imagine that over time you're going to be seeing more physicians who want to come and observe your cases. So I'll be excited to hear how that goes as time passes.
So we'll keep you posted, and even this eventually may be part of what is considered fellowship training, maybe in the next, hopefully 2 or 3 years, or not later than that. So in my location, at least, we are thinking of doing some sort of collaboration. Since I trained, that will be like my alma mater, so we can look into details like that as well for future trainees.
I think that is an incredible idea. Physicians they need to have this normalized in their mind as something that should be offered before surgery is even discussed, because Currently that's what physicians are, that's just the norm, what they default to. So having fellowship trained physicians that are exposed to this in their training, it just normalizes it and helps continue the spread of these types of non-surgical options. Obviously, laser being one factor. What sets your practice apart from other endocrinologists?
Honestly, it's a good patient care. That's what you need at every single area inside of endocrinology, for example. In our case, for large thyroid nodules, the opportunity to prevent a surgery, maybe avoid complications, is a plus. We also have some other techniques that we use doing thyroid procedures in the office, like alcohol injections. We do a lot of imaging as well in the office. So that's probably a little bit of a difference. We might be maybe one step ahead in what is considered interventional endocrinology. There's a movement going around using that terminology. So we think that we offer that, as well as some other unique insight, especially of endocrinology services in our practice.
I'm interested to know, is there a place for PEI in cystic nodules or nodules with cystic components? Or would you do an aspiration and then a laser procedure? Or is there ever a time when you would do a combination of the two?
Yeah, so this is an interesting topic, and it's something that has been used for some time. Not every endocrinologist will perform it due to certain limitations, maybe lack of training or skill. Getting the proper alcohol for the injection lately has been an issue, but that's something, and again, that could be a limitation factor. So the concept of percutaneous ethanol or alcohol injection is to treat large symptomatic thyroid cysts. Normally, thyroid cysts, when they occur and they are large, they can affect you cosmetically. They can give you local symptoms. So that's an approach that can be easily done to remove the fluid. Unfortunately, there's a 70% chance of recurrence or reaccumulation of fluid. So the layers inside the cyst may produce the fluid again. So when that happens, that's when the alcohol comes into play. Most thyroid specialists will tell you that after one aspiration, if there's reaccumulation, they will use a procedure. And there's different formulas to calculate how much alcohol will you inject, if it's in 1 or 3 separate sessions. But this is a very good success rate. So in a simple cyst, after drainage with reaccumulation, if PEI is used, there's great data on lack of recurrence. So patients' satisfaction is there, no more cosmetic discomfort or symptoms. I actually had the opportunity to present a small case series on this in one of the endocrine society meeting, I believe it was in 2021. So in conjunction with now a fellow in endocrinology, we did that work. It's something that it's available in the literature for some years, but again, it's lacking popularity. I guess it's a lack of training. Now, getting back into the question of the complex cyst for laser ablation, if you have a large cystic pocket in a complex or mixed nodule, solid and liquid, it's better to remove the fluids first before doing any of these thermal ablation procedures, because that temperature can go up, and you can imagine what will happen if you have something encapsulated and the temperature goes up, right? So that's a big no-no. So fluid aspiration first. Some experts have done alcohol injection before laser. Normally they wait a month or two to then go and bring them for the ablation procedures. One of the cases that I performed, we had to remove 2 medium-sized pockets. We did not use alcohol, but it's been used and reported the combination of both. Maybe the sclerosis or that scarring, we could say, may also help with the coagulation or burning, we could use the term, of the cells after laser ablation. A separate point, if I can bring it up now, is that in my experience, we talk about sizes of nodules, if they're compacted, very solid versus complexes. And there's some discrepancy, larger nodules, maybe radio frequency could be better reduction on volume, and that's in the literature, and that's a factor. But sometimes complex nodules, even the big ones, more than 30 mLs or bigger even, when they are complex, they tend to respond extremely well with laser ablation therapy. Some experts will say more than 30 mLs, think more radio frequency. I will say yes if it's completely solid or compacted. When it's more complex or spongy form, maybe the size may not matter, because there's good data And there was a recent publication up to follow-up of 26 patients, I believe it was, for 4 years, with good resolution of these large nodules using laser ablation per se.
So the texture of the tissue being more spongy is just more amenable to laser treatment. Is that what you're saying?
Yeah, some of the major papers looking in what we could say long-term follow-ups, either 4 years. There's another paper that was published in 2021. I think it was a group of Dr. Gambelunge, also from Italy. They looked 10 years, 170 patients, I believe it was, looking into this, either nodule regrowth. And if you read into the paper, some of these complex or spongiform nodules, meaning cystic and solid pockets, tend to not recur or regrow, excuse me, when laser has been used. So that's something that I guess we're learning, right? This is available for at least more than 20, 25 years, especially in Italy, laser ablation. But we're starting to see more data collection. So this is a time to really see, okay, maybe procedure A, it's good for these scenarios, procedure B is for these other scenarios. At the end of the day, having 2 or 3 tools to prevent a surgery, to treat something minimally invasive, less than an hour in your office, it's what we all want. So it's good to recognize the different techniques and who qualifies for each one better as a patient.
I agree. I believe that having multiple options is always good. And I don't believe that we should say, RFA is great and laser's not, or the other way around, because there are definitely, as you said, certain situations that are more amenable to each of the two procedures. And the main point that we need to remember is that all of them help patients avoid surgery. And is there a size limit in what is the acceptable treatable size?
Yeah, so that's a good point, and it's interesting because probably some years ago, I will say maybe 2018, around that time, we will say, and we still use the size criteria, saying more than 3 centimeters, 2 negative biopsies, you qualify for either any form of ablation procedures. Some experts will tell you even more than 2.5 centimeters with the 2, of course, benign thyroid biopsies. Nodule sizes that we're seeing in practice right now, probably somewhere between 3, 3.5. Largest one was close to 5 centimeters complex nodule. There's a new movement to standardize terminology in size. And there was a paper published, I think it was in 2019 or now in 2020 in the Thyroid Journal, which is probably the biggest thyroid journal publication, that they were trying to use criteria of size based on milliliters. So less than 15, it will be considered small, more than 30 mLs, usually big, and then we have the sizes in between. So it's either that criteria or the standard 2.5, 3 centimeters.
And, just as a side note, I kind of like the idea of milliliters versus dimensions because it really gives a better sense to, at least to me, to the size of something, because we're discussing the volume rather than the dimensions. It's harder for me to think in 3 different dimensions, but milliliters is one number, and it's just easier to kind of quantify that in my mind.
Right, right. And again, even for laser ablation specifically, sometimes you do calculations based on volume for how much energy you're going to use, decision on the number of fibers for the proper technique. So, yeah, definitely, I think that's going to be the standard terminology moving forward.
So you mentioned prior that you had a patient that traveled from out of the country to access laser. Can you tell me a little bit more about how? I know you said you've done about 4 cases. Are you
Yes.
seeing mostly local patients?
So 1 out of the 4 was out of town. An old patient of mine that we have been talking about this interestingly for at least 2 or 3 years. Then the pandemic came, so he couldn't travel, etc. But he had this large nodule, visible, some local discomfort. So we kept in communication to measure or send ultrasound reports to determine nodal growth. Multiple biopsies were performed until we decided to actually, I was able to communicate with him directly as soon as we had equipment, because around of the time that I went for training, he was seen in the office for a regular checkup. And I told him, listen, this could be happening, but we have been talking for the last 2 or 3 years. It's finally here. So he was very excited. He didn't want to pursue surgery, was trying to avoid it at all costs. Now in June, he's coming for his 6 months follow-up. So he's feeling okay, had no complications. I saw him after 1 month. You could see some improvement already in volume reduction. He will tell you that he felt less pressure even the same day when he left after the usual 20-30 minute observation that we keep them. He went, I clearly remember the picture of him going to the bathroom and coming out saying, I even see it less full now. I don't know if it was true, maybe the pocket of fluid that came out, but in any case, so far he's pretty pleased.
Yes, I'm sure he was very excited when he was finally able to come and have that procedure done. And as he expressed the feeling of improvement immediately, shortly after the procedure, I experienced that within about a week of my procedure, feeling just like my swallowing was better, my breathing was better. I had a lot of symptoms where, because of the location and size of my nodule, if I turned, that would make me feel lightheaded and dizzy because of the pressure. That was already starting to dissipate. So it's life-changing for patients when they experience these symptoms going away and without having surgery. I hope to hear more about him in the future when he's
For sure.
continuing.
I'll keep you posted as soon as I see him. Another thing that I forgot to mention, when we had the initial conversation, his nodule was very large. So we had, which I think it's also a part of the discussion when I see patients, that it's with laser per se, sometimes a second, quote unquote, second procedure might be needed. And it's important to be realistic or straightforward, so the patient is aware that if they don't achieve the 50% or more reduction, they may get it in a second session. So that is something that with him we may have to discuss, but we'll see in June. I'll keep you posted.
I had to have 2 procedures too. So I think a lot of patients are aware that that is a factor for larger nodules. And I think most of them are willing to do that considering they're avoiding a surgery. Are there any thoughts that you want to share that we haven't already discussed about laser or your practice or endocrinology in general?
Emphasize that this is accessible now. Sometimes there's cost that we could mention. There's tools that we have that you can finance your procedures, like when you go to a dentist. So we have that as well, specifically for laser. After we decided and we went over all the criteria for the procedure, patients are seen in the office. Using the proper techniques, the procedure is done. Again, it can vary between 20 to 40 minutes, depending how many fibers we use. More fibers sometimes indicate better success. At least in our practice, that may not change the cost. So it's important to emphasize again that we are in a time that this procedure might be covered. We have a good team of people checking insurances before even moving forward, for the benefit of the patient, so they know that they're covered. But if they have to come with a cost out of pocket, we can offer ways to finance it, or again, hopefully this helps to understand the public that in 2022, big chances to get it covered. If it's in our practice, we're going to help you to get this done in the right way, find ways for coverage. But ultimately, the goal is to preserve your thyroid, treat the nodule, and again, laser ablation, it's showing good data in nodule shrinkage or volume reduction, if we use a proper term. So we are seeing these again in the follow-ups every 3, 6, and 12 months. That's the standard of care. So very excited to be able to offer in our practice here in South Florida this laser ablation technique.
Thanks so much for watching. Make sure you subscribe and ring that little bell so you don't miss the next video. I have lots of exciting content coming up in the near future about RFA, PEI, laser ablation, traveling for treatment, and so much more. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.